Welcome back. And the next talk is from Dr. Mark Sabatine, who is a professor of medicine, the Louis Dexter Distinguished Chair in Cardiovascular Medicine, and chairman of the TIMI study group. He'll walk us through a discussion of acute coronary syndromes. Mark.
Great. Thank you very much, Dr. Desai. It's a pleasure to be back at IRIM, even though we're remote. I think it's a wonderful platform to cover this important topic. So I've been tasked with covering acute coronary syndromes in a scant 40 minutes. I'll start going through and have some cases as well. Here are my disclosures. Okay, let's start by framing how we think about acute coronary syndromes. And on this graphic here, we can start on the right-hand side where you can see an image of a coronary artery cut in cross-section with plaque rupture and a complete thrombotic occlusion of the coronary artery. To the right of that, you can see a snippet of an ECG that shows ST segment elevation. And so this is in then the realm of the ST elevation acute coronary syndromes. And as these patients almost invariably have evidence of myocyte necrosis, they are the ST elevation MIs. So that's relatively straightforward. On the left-hand side, I show you another cross-section of a coronary artery, again with plaque rupture, but here with a subtotal occlusion of the coronary artery. To the immediate right of that, you can see an ECG that shows ST segment depression. And so this then has us in the realm of the non-ST elevation acute coronary syndromes. They may or may not show ST segment changes. Again, the ECG here shows about 1 millimeter of ST segment depression. The patient may have that, but they may have had it only transiently at the onset of the ACS, and by the time you see them in the emergency room or on the floor, their ST segment may have normalized. They may or may not have T-wave inversions as well. Below that, then, show how we integrate the biomarkers. I show both CKMB and troponin with that rainbow triangle. And if the patient has an elevation of a cardiac biomarker of necrosis, now typically troponin and more typically high sensitivity troponin, then the patient would be deemed to have had a non-ST elevation myocardial infarction. And the different lengths of the triangles here between troponin and CKMB are meant to convey the greater sensitivity and as well specificity of troponin. There's still a sliver there for unstable angina, which by definition will be a clinical diagnosis because, again, the patient may or may not have appreciable ECG changes, and for unstable angina, by definition, they won't have elevation in the cardiac biomarkers of necrosis. At the very bottom, I show some older terminology for Q-wave and non-Q-wave MI. We have really abandoned that terminology. The reason is really twofold. First, you can see there is, if you will, some crosstalk, meaning not all ST elevation MIs develop Q waves. And even some cases of non-total occlusions of coronary arteries, small Q waves can be apparent. More importantly, the Q waves typically don't develop for hours, whereas our branch point for decision making in terms of whom to bring to the cath lab needs to be made immediately, and therefore we really classify ACS on the basis of the ST segment. Now, what about the electrocardiogram? We've talked a little bit about it. So what to look for: ST segment elevation or a left bundle branch block not known to be old, i.e. a new left bundle, ST segment depression as little as 0.5 millimeter, or T-wave inversions greater than 1 millimeter are significant. And then, of course, we want to look to see that these are in a coronary distribution. What else to look for? Either Q waves, which could be indicative of a late presentation of the current acute coronary syndrome, or perhaps evidence of a prior myocardial infarction, or form fruste of that poor R-wave progression. And then how to look at the ECG. Certainly looking at an ECG within 10 minutes of presentation, always compare to prior ECGs. That's critically important to do. But also don't forget to get serial ECGs. The initial ECG can be non-diagnostic in a large proportion of patients. So serial ECGs will give you insight into evolution. And then consider right-sided leads if there's inferior ST segment elevation, to further try to characterize whether it's proximal or distal. The proximal occlusions will also cause evidence of ST elevation on the right-sided leads involving the right ventricle. And then posterior leads in patients who have persistent anterior ST depressions or concerning history and a normal ECG, because the circumflex territory is not well covered on the standard 12-lead ECG. Okay, ruling in and ruling out an MI. So here we have the first case. This is a 75-year-old man who presents with chest pain for 15 minutes. That started 4 hours ago. Now is resolved. The ECG is without abnormalities. Your biomarker testing strategy is either A, check a troponin now, and if undetectable, discharge them to home. B, check a troponin now and in 1 hour. And if both the 99th percentile, both are below that and no change over time, you can discharge to home. And C, check a troponin now and 3 to 6 hours after symptom onset. And if both values are below the 99th percentile, then can discharge to home. So we're letting people vote here. Okay, good. So we have a lot of votes in. I'll say that the vast majority are choosing option C, check a troponin now 3 to 6 hours after symptom onset. Okay, let's go to, I think, the next slide then that will show the correct answer. And I am going to do that myself. Good, okay. Right, so I would say C is probably what is most commonly done, but I would say now we really can move to B. And the people who said A, I think, are being very avant-garde, and there are in fact data to support that. So let me go through some of these data. Okay, so as we thought about biomarkers, many of us trained in the era before troponin, where we would measure CK&B Q8 hours times 3. Then we had troponin, and we would typically measure Q8 hours times 3, just to mirror CK&B. As the troponin assays improved, it became appreciated that really a baseline test, and then one 3 to 6 hours later, would probably tell you everything you need to know. And now, with the advent of high sensitivity troponin, now we can measure troponin at presentation, and at 1 to 3 hours later, different studies have used different time points. And now we're going to examine not only the absolute values, but also the change. I'll indicate that here on the next slide. Here's the pathway we use at Brigham and Women's. And the slide has a lot of text. I don't expect you to read through it, but conceptually, on the left-hand side are the patients who rule in. How do they rule in? If either the baseline troponin or the 1 hour later is above the 99th percentile, then they rule in. Or if the delta, if it's going up sufficiently, that also constitutes a ruling in, even if that second value isn't above the 99th percentile. And it's the beauty of high sensitivity troponin is that there's enough precision at that lower level to enable us to distinguish these deltas, these changes over a short period of time. On the far right-hand side in green are the patients who've ruled out. Those are patients who have had very low levels and with a very small or no delta. And then there are patients in the intermediate zone who will need further follow-up. And as some people indicated, there are some data that if your troponin is undetectable, now that's lower than below the 99th percentile. That means having a value that is can't distinguish from water, so super low values, those people actually have an incredibly low risk of ACS, and in some studies have been sent home safely right from the ED after that initial value. Okay, so now let's transition to the ST elevation MIs. So those are patients in whom we want to consider immediate reperfusion therapy, in whom those who present within 12 hours of symptom onset. After 12 hours, we start worrying that there's just been irreversible myocyte necrosis. But that being said, we err, if you will, on the side of taking them to the cath lab if the ECG still has evidence of ongoing ischemia, if there are any symptoms of ongoing ischemia. How do we reperfuse individuals? Really, primary PCI is the preferred strategy, including transfer to a PCI-capable hospital. So if your facility can't do it, it's still the preferred strategy is to transfer to a hospital that can do primary PCI. If the door in to door out time is less than 30 minutes and the first medical contact to the PCI is anticipated to be under 2 hours. If you can't do primary PCI, then fibrinolytic therapy would be indicated with the usual absolute and relative contraindications listed at the bottom of the slide. Okay, so second question here. Now we have a 65-year-old man presents with a STEMI, his inferior ST segment elevations. He's brought for immediate angiography and found to have an occluded RCA, which is successfully stented, and the patient's doing well. Also noted to have an 80% mid-LAD lesion and a 50% circumflex lesion. How would you like to manage this patient? Low-level stress test before discharge, stent the LAD lesion during this hospitalization or within 6 weeks, or while they're on the table, stent the LAD in the left circumflex right now. So let's have people vote. Good. Okay, I'll say we have about 3/4 or so who would stent the LAD lesion during this hospitalization or at least within 6 weeks, and then small minorities who would either do a stress test or stent everything now. Okay, very good. And I think B is what I would say, is the correct answer in this case. And so why do we do that? It's this notion of preventive PCI and STEMI, a relatively new concept. Tested in some smaller trials and most recently in the larger complete trial, 2,000 patients with STEMI and multivessel disease. And the strategy was either revasc of all significant lesions. By that, it was angiographically at least 70% or 50 to 70 with an FFR that was less than 0.8 within 45 days. So it didn't have to be on the table, but within that hospitalization versus just doing the culprit. And you can see with modern stenting techniques that the more complete revascularization actually led to a lower risk of CV death or MI. And so we've now moved towards fixing these additional lesions. So you'll see that for the patients coming in with a STEMI. Typically, the approach is fix the culprit right when they come in, but either during that hospitalization or in about 6 weeks or so, go after other significant lesions because we know these patients are at high risk. All right, now let's pivot and talk about non-ST elevation acute coronary syndromes. Some more variables here for how to manage them, so a little bit more complexity. On the left-hand side of this slide, I show sort of the paradigm, the plaque rupture and a subtotal coronary occlusion. Patients will get initial medical therapy. We'll talk about that in a bit for anti-ischemic and anti-thrombotic therapy. And then the major branch point is whether they're managed so-called invasively, meaning routine angiography for all patients within 48 hours, or conservatively, otherwise known as selective angiography. And by that, it means they continue to marinate in whatever antithrombotic therapy you've started. And then they go to the cath lab only if they have recurrent symptoms or they have a high-risk stress test. Otherwise, they're managed medically. Let's see what you would do for this patient here. So this is a 72-year-old woman. She presents with chest pain that started 3 hours ago. The ECG shows inferior ST segment depressions. The troponin is elevated. She's now chest pain free and the ECG has normalized. So your options are stress test within 48 hours, cath immediately, cath within 24 hours, or send for cath within 72 hours. So let's see how the votes start tallying. Okay, I think we have a pretty clear winner here amongst the audience, and that's cath within 24 hours, with about 10% voting for the other options, each of stress test, cath immediately, or cath within 72 hours. Okay, well, I would say I think that is the correct answer. I think there's certainly nothing wrong with cathing the person immediately, though that's easy for me to say as a non-interventional cardiologist, but there's certainly nothing wrong with that. Cath within 72 hours, probably we'd want to do it a little bit earlier for this person. And let's go over the data and see why that's the case. So this issue of invasive versus conservative has been studied for many, many years. In fact, for such a long time that we've actually done 2 trials at the TIMI study group, TIMI 3B and Tactics TIMI 18, looking at this issue. Michelle O'Donoghue in our group led this meta-analysis, now a decade old, but very nicely showing that an invasive strategy reduces the risk of cardiac complications by about 20%, particularly for recurrent acute coronary syndromes. And so in general, for patients, we favor an invasive strategy. But one size does not fit all. And so this was an analysis that we did in Tactics TIMI 18 that Chris Cannon led the trial and Dave Morrow led the biomarker study for the trial. Overall in the trial in Tactics, an early invasive approach shown here in the crimson did better than a conservative approach. What we're showing on this slide is stratifying patients by the troponin level. And so for patients who had a negative troponin, this is an older assay because this trial was done 20 years ago, on the far left, there was no clear benefit to an early invasive strategy. In contrast, for patients with an elevated troponin level, so the 3 paired bar graphs on the right, then you can see a very big benefit with a significant reduction in the odds of death MI or ACS through 30 days with an invasive approach. So that suggests if you're high risk with troponin positive, you would have an invasive approach. And our patient did have a positive troponin. What about the timing? That was an additional wrinkle I put into the questions. Well, that was studied by Shamir Mehta in the TIMAX trial, asking for these patients, all of whom went to the cath lab, should they go within 1 day? And typically it was about a half a day median of 14 hours, or go after 36 hours, and that typically was a median of about 2 days. The overall primary endpoint just missed significance. It was a 15% reduction, but the confidence interval span 1. But for a more coronary-focused outcome of death MI and refractory ischemia, there was a very clear reduction, a 28% reduction. And shown in the bottom, a forest plot showing that for the patients at higher risk with elevated cardiac biomarker or high integrated risk score, in this case, the GRACE score, there was a bigger benefit there. So for our patient who was high risk with a positive troponin, I probably would cath them within about 24 hours or so, as the majority of people answered. So that's very good. And so when we wrote the 2014 guidelines, this is how we binned it: immediate coronary angiography for patients who have refractory angina, symptoms of heart failure. Those people need to go immediately. Early invasive within 24 hours are the patients who have a particularly hot ACS, so elevated troponin, ST segment depressions, high Grace score. Otherwise, if they're a higher risk patient, but without those particularly high risk features, then they should go to the cath lab, but you have the luxury of waiting about 3 days or so. And then the very low risk patients can be managed conservatively. Okay, I'm not going to dwell a lot on anti-ischemic therapy. I think that's going to be familiar for most people in the group here. Nitrates give symptomatic relief. Beta blockers decrease ischemia and decrease death or MI. Long term, just be careful that the patient isn't in heart failure or at risk for shock. And you want to use the beta blockers orally. So if it's a marathon, not a sprint for the beta blockade. Calcium channel blockers we generally avoid, only really consider them if the patient has ischemia despite maximum beta blockade, or if they can't get beta blockers because of reactive airway disease. That's pretty rare. And then morphine is reasonable to try to treat that little bit of residual pain, but you really don't want to mask refractory angina. And then oxygen if the patient's hypoxemic. So I won't dwell on that any further. What we will get into now is the complexity of antithrombotic therapy. Lots of different options here. Let's start with a case. 65-year-old man presents with chest pain that started 2 hours ago. ECG shows anterior ST segment depression. Troponin's elevated, has already received aspirin. Question is, what other antiplatelet therapy are you going to give? A, do you add clopidogrel? B, do you add prasugrel? C, do you add ticagrelor? D, do you add an intravenous P2Y12 inhibitor, cangrelor? Or E, do you add an intravenous 2B3A inhibitor, eptifibatide? All right, let's see what people vote. Okay, I think it looks like a split decision in the group. I'd say between clopidogrel and ticagrelor would be the ones getting the most votes, with a handful of people for the other choices. Okay, let's go to the next slide. In this case, I would give ticagrelor, and let me go through the data that support that choice. So antiplatelet therapy acutely, how do we think about it? Perhaps just for historical reasons, but we always start with cyclooxygenase inhibition, so that's aspirin. We almost always then add on top of aspirin a P2Y12 ADP receptor blocker, and that in that case, ticagrelor or prasugrel is really preferred over clopidogrel, and I'll show you why. Sometimes we also add a 2B3A inhibitor. This is almost always done in the cath lab. So why do we give prasugrel or ticagrelor over clopidogrel? This was studied in Triton TIMI 38 that Steve Wiviet led. Compared to clopidogrel, prasugrel, the more potent P2Y12 inhibitor in patients with planned PCI and obviously ACS, reduced the risk of death MI, CV death MI or stroke by 19%. With about a 2% absolute risk reduction and only about a 0.5% increase in bleeding. So more potent P2Y12 inhibition further reduces ischemic events. Same story for ticagrelor versus clopidogrel in the Plato trial. Again, the theme, the more potent P2Y12 inhibitor, the greater the reduction in ischemic events, including in this trial a reduction in cardiovascular death of 21%. When we did the guidelines, although you can give any of the three, clopidogrel, prasugrel, or ticagrelor, we note that it is reasonable to use ticagrelor in preference to clopidogrel and reasonable to use prasugrel in preference to clopidogrel. Interestingly, a real wrinkle here is the ISAR React 5 trial, a trial that showed that in patients with ACS, that prasugrel seemed to have a lower risk for death MI or stroke than ticagrelor. I think as a community, we're grappling with these data. It was a very well done trial. It's just surprising given how similar the platelet inhibition is for those two drugs, given that the risk reduction seen with each of those versus clopidogrel was quite comparable, that in a head-to-head, there'd be this magnitude of difference. So I would say, in my mind, the jury is still out. This certainly reinforces that you can give prasugrel, even though it's not as commonly given, that it really works wonderfully well. So I think either of the third generations are reasonable to give. Both have been shown to be superior to clopidogrel. And between the two, I think we still have equipoise and really need more data. Anticoagulants. This is a little simpler because here we're not layering additional therapy, we're choosing one. And so most commonly we give unfractionated heparin, fast on, fast off. Sometimes we'd give low molecular weight heparin. That is typically more for conservatively managed patients, just because of its longer half-life there. And then sometimes we give bivalirudin, like unfractionated heparin. It's fast on and fast off. We typically consider that in invasively managed patients, particularly for those at high risk for bleeding. So now we've covered sort of the acute part. Now the notion is, if you're going to send the person home, what are you going to send them home on, and for how long? So 64-year-old man, non-STEMI, drug-eluting stent put in the LAD. In addition to lifelong aspirin, you would also recommend the following. Would you give the P2Y12 inhibitor just for 30 days? Would you give it for a year? Would you give it for as long as tolerated if the person's at high ischemic risk and low bleeding risk? Or would you give low-dose rivaroxaban instead? So let's see the votes now. All right, I would say there's a strong majority giving P2Y12 inhibitor for 1 year. About a sixth of people would also give it for longer or so, and then a smattering for other votes. Okay. And so I think, I'd say that the data really support, in this case, either P2Y12 inhibitor for as long as tolerated, if at high ischemic risk and low bleeding risk, or adding low-dose rivaroxaban. But the data are very complex, and certainly probably what's most commonly done is what people voted for B for 1 year. But let me share some data for why we might want to consider giving more aggressive antithrombotic therapy for longer. And so here's one example. These are data from Pegasus TIMI 54. These looked at patients just like this one. They had an MI. They had gotten their therapy for aspirin and a P2Y12 inhibitor for a year. And then we said, well, let's look to see beyond that point. Why should we stop? Might there be additional benefit? And so on a background of aspirin, continuing on, in this case, ticagrelor, reduced ischemic events by about 15%. So that's one bit of data for more prolonged P2Y12 inhibition on a background of aspirin therapy. And these are the COMPASS data saying for patients with stable ASCVD on a background of aspirin, you get some benefit by adding rivaroxaban, very low dose, not the AFib dosing, very low dose. So some data that our patients who have had ASCVD, particularly the patients with MI, they're at high ischemic risk, and we need to do more than just have aspirin monotherapy. More complicated, though, is what that therapy should be. And so Michelle O'Donoghue in our group nicely has shown that if you meta-analyze a series of trials that have looked at patients with ACS who you then drop the aspirin. So even though we think of that as the old standby, there are trials that have looked at dropping aspirin. You really decrease the risk of bleeding, and there really doesn't appear to be a price to pay for MACE. So this has opened up the notion that really maybe the answer is long-term P2Y12 monotherapy for our patients. All right, now this issue always comes up. It's very vexing. What about so-called triple therapy? So we have a 72-year-old woman, hypertension, diabetes, prior stroke, presents with a non-STEMI, 2 stents placed in the proximal LAD, put an aspirin and ticagrelor, all is going well, then the next day develops atrial fibrillation. What regimen do you discharge her on? Warfarin with an INR of 2 to 3, aspirin ticagrelor, full dose NOAC or DOAC, aspirin and clopidogrel, full dose NOAC and clopidogrel, drop the aspirin, or reduced dose NOAC and clopidogrel. Let's have the votes now. All right, this is clearly a tougher one as we have fewer people voting. And I would say, though, the majority have chosen full dose NOAC and clopidogrel, with some opting for triple therapy with the NOAC and some contemplating reduced dose NOAC, and very few for warfarin as triple therapy. Okay, this is a hard question. And I've listed, both B and C would be reasonable. I have to say I probably would move more towards C for this person. What are the data out there? So it's very complicated. I think there's a few take-home points. I'll just try to summarize. Eliminating aspirin definitely decreases the risk of bleeding. That's been quite clearly seen. And patients on triple therapy are at very high risk for bleeding. Some regimens that have dropped the aspirin have shown maybe there's a bit of a price to pay with numerically increased rates of MI. Stent thrombosis, though, itself is very rare. And regimens that looked at reduced dose, DOAC or NOACs, had numerically slightly higher rates of ischemic stroke versus regimens with warfarin with an INR of 2 to 3. So the most recent trial that's looked at this is Augustus, a 2x2 randomization to either apixaban or warfarin and to aspirin versus placebo. Everyone gets background P2Y12. Take-home point, best regimen for bleeding, apixaban and placebo. For ischemic risk, pretty comparable, and at least for those on apixaban, if you drop the aspirin, that green bar at the end, there didn't appear to be a price to pay. And so I personally, based on these data, I do feel comfortable dropping the aspirin. I wouldn't give a reduced dose DOAC. I think the stroke is a devastating complication, and we don't have enough confidence that the reduced dose DOAC regimens really truly protect against stroke. So I would start with, when they come in, aspirin, ticagrelor, and then if they need apixaban or if they need an anticoagulant, apixaban, and then I would drop the aspirin. The exact timing in Augustus, it was after a week or so on average, and given the irreversible effects of aspirin for about a week or so, they really got 2 weeks of aspirin therapy, if you will, and so probably dropping sometime at the end of discharge or soon thereafter. Last couple things to talk about, last few slides, lipid-lowering therapy. So 64-year-old man, history of non-STEMI 2 years ago, now presents with another non-STEMI. Has a drug-eluting stent placed in the LAD. Has moderate lesions in the RCA and the circumflex, but no need to intervene in them at this time. The LDL cholesterol on admission, not on any lipid lowering, was 180 milligrams per deciliter, started on a tour of 80 milligrams. What else would you recommend for this person? So do you just target a 50% reduction and be content with that? Do you just want to get their LDL down to 70 and content with that? Would you also add ezetimibe? Would you add a PCSK9 inhibitor? Or would you do the kitchen sink, add ezetimibe and or PCSK9 inhibitor to drive the LDL cholesterol well below 70? And provocatively, I'll say at or below 40 milligrams per deciliter. A lot of different approaches here. Let's see what people vote. All right. I'll say that the majority of people would say target an LDL cholesterol of 70, and that's certainly true from the guidelines. But in terms of feeling there's the need to add something else, about a quarter of people have said they would add something else, and a variety of opinions for what to add. Show a few slides to speak about this. Personally, I would do E, although I wouldn't argue that the guidelines would say B for the person, and depending on the LDL, then considering C or D. Why do we target 70? Prove It TIMI 22 and ACS showed that high-intensity statin good, and that achieved an LDL under 70, a median of 62. We did Improve It, showing that for people whom with a statin had an average LDL of 70, that you could lower their risk by further lowering their LDL by adding ezetimibe. The relative risk reduction here is modest. That's because ezetimibe only lowers LDL by about 25% or so, but further lowering reduces events. We showed in the Fourier trial that with a more potent LDL cholesterol-lowering drug, evolocumab, a PCSK9 monoclonal antibody, we reduced LDL down to less than a millimole, less than 40 milligrams per deciliter, and reduced the risk of CV death, MI, or stroke by 20%. Also seen with alirocumab in Odyssey outcomes here, again, a reduction in events with adding a PCSK9 inhibitor. The guidelines, at least for the American guidelines, do comment on looking at the LDL cholesterol, and if it's above 70 treating, I have to say the data really points to far more aggressive therapy. All right, let me end to leave just a little bit of time for questions. Other things, beta blockers, we talked about acutely. Certainly, once the patient has stabilized, adding a beta blocker reduces the risk of MI or death by about 25 to 50%. So they absolutely should go home on one. ACE or ARB if they can't tolerate ACE, great if the EF is less than 40% or any excuse, hypertension, diabetes, stable CKD, and then an MRA, mineralocorticoid receptor antagonist, if they have a reduced EF or they have diabetes or clinical heart failure. So to summarize, to leave a couple minutes for questions, you diagnose ACS using history and physical, 12-lead ECG and troponin. For STEMI, the issue is typically going to be primary PCI. For unstable angio or non-STEMI, you're going to choose between an early invasive approach, typically in the troponin-positive patients, versus a conservative strategy. You'll treat your patients with beta blocker and nitrates. You're going to pick your antiplatelet regimen. We're going to start with aspirin and add a P2Y12 inhibitor, preferentially one of the more potent ones, ticagrelor or prasugrel. We'll select an anticoagulant, almost always unfractionated heparin, long-term aspirin, P2Y12 inhibitor, some debate about dropping the aspirin, but certainly keep the P2Y12 inhibitor going for a long time. Beta blocker, statin, I would typically add ezetimibe and PCSK9 inhibitor to drive that LDL cholesterol down. And then for appropriate patients, ACE inhibitor and aldosterone inhibition. So I'll stop here and see if Dr. Desai, there are any questions.
Yeah, thanks so much, Mark. A really excellent overview and a number of questions, most of which center around any platelet therapy and biomarkers. So let me take those in sequence. For P2Y12 inhibitors, you've shown a lot of data from ICAR React and other trials about the superiority of the newer antiplatelet agents. So should we be loading those upstream in patients? And if so, what should we be doing in the ER?
I was hoping no one would ask that question because it's a really tough one. It's hard. I would say that Plato looked at loading people in the ED, and so that has been my usual practice. That being said, for trials that have looked at early in the ED or even pre-hospital versus at the time of cath, they haven't shown any benefit to pre-treatment. And there is some risk that if the patient has 3-vessel disease or left main and needs cabbage, you have to delay that a little bit. I would say if the person's going to the cath lab almost immediately, I would just wait till the anatomy is defined. If it's going to be a long time, if they come in on a Friday and they're not going to be cath till Monday, I probably would treat them with a P2Y12. Cangrelor, I didn't have time to discuss, is another option. It's an intravenous option. It's fast on, fast off. It's very expensive, but so it's an attractive pharmacologic option. As I think as the costs come down, it's then a great way to treat people early so they're covered, and then you're not committed to long-term therapy.
Perfect. And then a number of questions really that get to this question of duration of antiplatelet therapy after acute coronary syndrome and intervention. Maybe you could speak to that, and then as part of that, the management around procedures.
Yeah. So, the field, it's sort of, we're drowning in data and not all of it appears, at least at face value, concordant. What are the general principles? So more potent antithrombotic therapy for longer decreases events. That's all been done on a background of aspirin therapy because historically that's what we've started with. people have now started to ask, and there's some platelet data to suggest that on the background of a P2Y12 inhibitor, maybe the additional antiplatelet effect for aspirin is pretty modest. And that's why there's been now about 5 trials looking at withdrawing aspirin. And in that setting, then there's definitely a decrease in bleeding with no clear risk in terms of increased risk of MACE. So I think most of us would start with DAPT for the first month or 3 months, depending on sort of the complexity of the coronary intervention. There's there's a trial just starting now that will look at dropping aspirin at hospital discharge. But for now, 1 to 3 months, and then consider dropping the aspirin. I think more so if they're at high bleeding risk. You may want to keep it on if they're at higher thrombotic risk. Keep the P2Y12 going long term. I would use a more potent one like ticagrelor. And then if someone needs a procedure, that's a debate with the surgeons or the proceduralists. People tend to be more comfortable doing a procedure on aspirin than on P2Y12. But I think as we move towards P2Y12 monotherapy, there'll need to be the comfort and needs to grow for that, because I think that'll become the new default.
Thanks so much, Mark. I think we'll close there. Excellent survey of a really complex field. So thanks again.